Okay, good morning, and thank you for joining us for today's webinar on the Prostate Cancer Working Group Criteria Review. My name is Catherine Chintala, Project Manager at Merit. For those of you who are attending for the first time, we're delighted that you could join us, and of course, we extend our deepest appreciation to all returning attendees as well. In this webinar, we will be discussing the principles of the PCWG3 response criteria, as well as imaging modalities such as bone scans and PSMA PET CT. We will leave time at the end for any questions you may have. Not only will this webinar be a great introduction to this response criteria, but it will also provide helpful guidance on the application of PCWG3 in clinical trials. If you are joining us live for the first time, you may also view our previously hosted webinars on our website at www.meritcro.com under the Resources tab. You can select webinars and replay your on-demand webinar of choice. We also host this content on our company's YouTube channel. Please note we are recording this webinar so that it can be added to both our website and YouTube channel for replay. All attendees will receive a follow-up email with a link to this recording, which we welcome you to share with fellow colleagues and industry connections as you see fit. All participants will be muted during the presentation. However, we will devote time to questions and answers at the end. We invite and encourage you to submit questions at any time throughout today's presentation via the Zoom Q&A functionality. Our presenters will address as many questions live as time permits, and all remaining questions will be answered directly via email following the webinar. I am so pleased to be joined by my colleagues, Dr. Kim and Matthew Hoover. I would like to start off by introducing Dr. Gene Kim. Gene is Merit's clinical scientist, and he has worked to implement various reading criteria into our Excelsior software platform, delivering read workflows, functionality, and algorithms to support independent central review. Matthew Hoover is Merit's Oncology Partnerships Executive. Matthew brings a unique perspective to our oncology team and business development group. With a background as a registered nuclear medicine technologist, Matt has extensive experience in both the business and the patient side of clinical trials. And now, without further ado, I would like to turn the presentation over to Dr. Gene Kim. Okay, Dr. Kim.
Thank you very much for the introduction, Catherine. And thank you everyone for who's joining for our discussion today. So we'll be talking about the Prostate Cancer Working Group 3 criteria and its basic fundamental rules, and followed by some imaging modalities. So first of all, Prostate Cancer Working Group 3 criteria is developed by the working group. Since 2008, there was a Working Group 2, and they follow up on the 2016 publications on suggestions about this metastatic castration-resistant prostate cancer with the primary tumor site of the prostate, with possible bone metastasis, and also the visceral soft tissue metastasis as an imaging assessment methodology. So this PCWG3 working criteria suggests to use response criteria as it is presented over here. Any visceral and soft tissue metastasis will be assessed by conventional RECIST 1-1 using CT or MR as their primary imaging modality, followed as the RECIST 1-1 guidance. Due to the bone lesion being a very common site of the metastasis in many of the prostate cancers, and there are also some other issues about the bone lesion flares, PCWG3 suggests particular rules reading a bone scans using a nuclear medicine. So there are two compartments in PCWG3 assessment, which will be a RECIST 1-1 for rest of the body parts and the bone lesion following the PCWG3 particular rule, or oftentimes they refer to as a 2+2 rules. Over response can either be reported in the separate segregated two compartments, or either can be combined per protocol or charter specifications for clinical trial design. And then I'll hand this presentation briefly to Matthew for a bone scan imaging modality.
Thank you, Dr. Kim. To perform bone scintigraphy or a nuclear medicine bone scan, there are no contraindications. Patients are free to continue taking their standard medications and can eat and drink prior to their appointment. The imaging procedure itself is fairly straightforward, and the entire exam generally takes around 3 to 4 hours to complete, while the actual imaging portion of the exam usually only lasts around 30 to 60 minutes, depending on the site protocol and if additional views are required. The exam starts with a general patient assessment, noting any recent trauma or injuries, to include biopsies, as well as bone pain. Once that is completed, the technologist will administer the radiotracer intravenously. There are a few different options for radiotracers. However, the two most commonly used imaging agents are either technetium methyl diphosphonate, or TECMDP, and technetium hydroxydiphosphonate, or TEC-HDP. Once administered, both of these radiopharmaceuticals are taken from the bloodstream by the osteoblasts, the cells responsible for bone building, and incorporated into the hydroxyapatite crystal matrix within the bone structure. Next. For radiopharmaceutical localization, it generally takes around 2 to 3 hours post-injection for the tracer to work its way from the bloodstream and to be incorporated into the bone structure. During the 2 to 3 hour uptake period, it is important for the patient to increase their fluid intake and void prior to imaging to minimize background radioactivity or noise within the image to ensure a high target to background visualization. As mentioned earlier, the actual imaging portion of the exam generally takes 30 to 60 minutes to acquire. Typically, a whole body or planar image is acquired, which is what we're viewing on this slide here. Additional common optional imaging maneuvers may include lateral or oblique imaging of an area of concern, or perhaps the imaging site will perform a SPECT or SPECT CT image of a region of interest, producing a 3D image of the bone structure versus a 2D image. It is important to note that not all hotspots are malignancies. Other common reasons for increased uptake or visualization of a hotspot on the images include recent trauma, such as a fall or bone biopsy, fracture, epiphyseal plates, and arthritic joints. In addition to ensuring that the patient history is completed in a thorough manner, it is equally important for the local imaging site to follow the study protocol to ensure optimal imaging results. As you may have noticed with this image, the bladder is visualized. While this is a common item to see on bone scans, it would be recommended that the local imaging site take a series of dedicated pelvic images immediately post-void to ensure that any potential osseous pelvic lesions are visualized versus being obscured by the bladder activity. Next. For reference, here's a basic overview of the imaging procedure that the majority of sites would fall under. The one item that I would like to highlight on this slide is the wide dosing range of the radiopharmaceutical. While 30 millicuries may be appropriate for a gamma camera that is 30 plus years old, which there are still many of those out there, believe it or not, taking wonderful diagnostic images, it may be simply too much activity for a newer solid state gamma camera that would use 15 millicuries or less dose. Regardless, this is one of the many items that our team here at Merit can help to ensure is addressed within the imaging charter to ensure your study data is based off of optimal imaging parameters. Now, Dr. Kim will guide us on the response criteria as it relates to osseous metastases.
Thank you very much, Matt. For the PCWG3 criteria, there are a few lesion categories that we can go over. So for extraskeletal lesions, as we discussed earlier in our slides, any non-bone lesions would be on their long liver, lymph nodes, and etc. locations will be assessed by the RECIST 101, which will be categorized under target lesions, non-target lesions, and new lesions, just like any RECIST 101 criteria. For the lesion category for the PCWG3 specific, it will be a skeletal lesions or the bone lesions. We'll be collecting these informations as necessary. There is no measurement or the number limits or the requirement that is specified of PCWG3 as opposed to RECIST 1 target lesion criteria. Record data information as the bone lesion ID and tumor state of the presenting absence status, and then bone lesion count at the baseline. Also, the anatomical location will be associated with the bone lesions as the radiologist will read through. And then also the record of lesions must be only to the bone lesions that are specifically related to a prostate cancer metastasis, and it should be avoided any lesions that are not really truly a malignant, such as fractures or other inflammatory processes that cannot displayed or visualized in the bone scan. Upon a follow-up, new bone lesions are also counted and followed. Again, there will be no measurements particular for the bone scans, except for the number counts. And then also there is no number limits. And these following informations will be recorded, which be a bone lesion ID of any identified lesions at the baseline, plus any new lesions will have a new associated lesion ID with the presence or absence status of each lesions being followed up, plus the new lesions status. Bone lesion count should be also counted for that particular visits with the anatomical locations, skull, thorax, spine, pelvis, or extremities as necessary. And then also the count difference of the bone lesion should be calculated, which should be recording a total new lesion number compared to the baseline and a week 8. So basically, how many new lesion has been appeared since baseline to the week 8. And also for any visits that is the post week 8 visits, also, we need to account for the new lesion count that has been compared to the week 8 new lesion versus the post week 8 new lesions. So any new lesion appearance number count also should be recorded. And also for the response criteria or the outcome itself, reported outcome will be per RECIST 1 for any soft tissue or the visceral metastasis following complete response, partial or stable disease, or progressive disease for the RECIST 1 part. And any of the rest, the bone scan part will be reported as either PD, progressive disease, or just simply a non-progressive disease. So the two delineations in outcome. Usually the imaging time point recommended for prostate cancer is about 8 to 9 weeks time points after the baseline. So for example, at the baseline before the treatments, they can take the baseline bone scans and other necessary imaging. And first imaging around week 8 or 9. There may be a predefined first time point if this is not something that might go along for particular therapies that is being under in that investigation. But usually, week 8 or 9 is a time frame they suggest due to any possible flares in the bone lesions to avoid any complications or confusing point for the readers. And then second imaging time point can go as scheduled for week 16th, 17th, and on. So for the response criteria rule, particular for the PCWG3, which also often is referred to as a 2+2 rule, is that progression defined using following rules. And that would be a first non-progressive disease or any other cases that does not meet the following the PD criteria. And the progressive disease would be a 2+2 rules, which should be at least 2 or more new lesions are seen at the week 8 compared to the baseline. And then if there's additional 2 or more new lesions found at the first bone scan after week 8. Or if one or new, if that's not the case, If one or less new lesions were seen at the week 8, for instance, at least 2 or more lesions are seen at the post-week 8 scans compared to the week 8, either at the same time or either it could be incrementally up to 2 lesions or more. And then those 2 or more new lesions are confirmed upon the follow-up visits, so that those 2 lesions are confirmed to be a new lesion. In that case, the progressive disease can be assigned upon backdating rules, so that originally identified time point for those new lesions will be a time point that the PD outcome will be associated with. So for instance, some quick imagings example is that upon a baseline, we'll have a bone scans. Week 8, bone scans will be captured again, which in these examples, I put as a star mark, indicating for the new lesion has been appeared since the baseline. And then now another post week 8 scan will be assessed. If there is another 2 additional new lesions, basically a 2 at the week 8 plus 2 at the post week 8 or the first scan post week 8. This will mean 2 plus 2, so that the lesion will be identified as 2 plus 2 will be a progressive disease for this example. And then also another example will be starting at the week 8. After the new lesions assessed as a week 8, there is a 1 additional new lesions at week 8 compared to a baseline, another 1 new lesions at week 16, another 1 new lesions at the week 24. So there will be a 2 additional new lesions starting from the week 8. And then that 2 new lesions that has been appeared since after the week 8 has been confirmed upon 32, still persisting. That will be a progressive disease confirmation upon another progressive disease rules suggested by the PCWG3. Also, here are some other more grading form rendered visualizations on similar stories here. Would be a bone lesions and a count. Basically, a new bone lesions in week 8 was identified with the anatomical locations here. Total new bone lesion compared to the baseline will be counted. And then also the week 16 total new bone lesions also counted compared to the week 8. None for this time point, as a 0 is recorded here. But at the week 24, there is a 2 additional new lesions has been appeared since the week 8, which is a 0.2 and 0.3. We count that post week 8. There's a 2 additional counts. And then that same 2 lesions are confirmed in the week 36. So these 2 lesions are persisting so that we give the PD to the week 24. And then we will be discussing briefly about the PSMA PET CT imaging, which is a rather novel compared to the technetium bone scans. I'll pass the presentation to Matt. Thank you.
Currently, there are many different variations of PET PSMA radiopharmaceuticals in various stages of development and commercial availability, which utilize many different isotopes and varying properties. However, for the majority of available PET PSMA radiopharmaceuticals today, the isotopes being evaluated or used are gallium-68 or fluorine-18. Regardless of which isotope is being used, the mechanism of localization is still fairly straightforward for most PSMA PET imaging agents. The imaging agent is removed from the bloodstream after administration and binds to the PSMA proteins on the surface of the prostate cancer cells. While localized, the imaging agent emits radiation, which is then detected by the PET imaging system and then used to create an image, identifying concentrations of the radiotracer throughout the patient. Thanks. To perform PSMA PET CT imaging, there are no contraindications. Patients are free to continue taking their standard medications, and just like Dave Matthews says, they can eat, drink, and be merry prior to the appointment. The imaging procedure itself is fairly straightforward, and patients should allow 2 to 4 hours to complete. In a nutshell, the patient arrives, completes a medical history, and medication reconciliation with the technologist performing the exam is performed, and an IV catheter is placed and the radiopharmaceutical is administered. Most facilities will allow the imaging tracer to circulate for around 50 minutes, then ask the patient to void in the restroom. And the aim of this is to be imaging the patient on the table at around the 60-minute post-injection mark. Imaging is typically performed between 50 and 100 minutes post-injection, and high-quality images have still been captured even up to the 3 to 4 hour post-injection time point. The imaging procedure itself typically lasts around 20 to 30 minutes, and the technologist should begin imaging at the pelvic region and work their way up towards the patient's head in order to maximize visibility within the bladder area. In the example images provided above, all 3 patients are positive for PSMA avid regions of interest, indicated by the green arrows. Generally speaking, the varying PSMA compounds are very good, being able to image roughly 95% of patients with prostate cancer with accuracy. However, there are some studies out there that have shown that there is a small population, around 5% of the prostate cancer patients, whose scan may produce a false negative result due to the lack or minimal amount of PSMA protein receptors on the cellular surface. Next. In addition to identifying soft tissue mets, the PSMA agents in development are fairly good at identifying bone metastasis. However, more information is still needed in this area, which is why the standard is still to include some form of functional bone imaging, such as the TEC-MDP bone scan we discussed earlier, or even a sodium fluoride PET bone scan as well. As you can see from the images above, which were taken of the same patient 1 day apart, the images are promising for detecting osseous lesions. As you can see, mild uptake on the TEC-MDP bone scan study on the left-hand side compared to the PSMA PET imaging agent on the right-hand side, which has identified widespread bone metastasis throughout the patient, which will most likely impact the treatment plan and potentially the overall outcome for this patient. So the main takeaway from this slide is to encourage investigators to consider embracing newer radiopharmaceuticals, imaging procedures, and modalities to ensure that you have the best available data for your study versus what has always been done simply because it's, well, the way we've done it. Next. And as with many different radiopharmaceuticals, it is important to note that hotspots, again, don't always equate to malignancies. Certain body habitus will certainly show varying degrees of uptake, which is not indicative of a malignancy, but rather is a common and completely normal biodistribution of the tracer. While each particular imaging compound varies slightly and requires reader-specific training, this is a good image that gives a sense of what areas of the body are commonly visualized and which are pathologically unremarkable. So for this particular compound shown above, fluorine DCFPYL, it is normal and not alarming to see intense focal uptake in the lacrimal and salivary glands, liver, spleen, kidneys, bowel, and bladder. Just another item that should be considered when performing PSMA PET CT imaging or any other nuclear medicine study for that matter, and when selecting readers to ensure that they have the appropriate training for the particular protocol being utilized. Next. Here is a basic overview of the imaging procedure that the majority of sites would fall under. It is important to note that this should be used as a general framework or guideline, and that there are still common optional maneuvers that can be incorporated into the imaging. Two of the most common optional maneuvers are the use of CT venous contrast during the CT portion of the exam, as well as administering furosemide or LASIX prior to imaging. The logic behind the furosemide is fairly straightforward. Since the imaging tracer exits the body through the urinary tract, the bladder tends to fill up with hot or radioactive urine. A common issue that prostate patients might experience is difficulty urinating or emptying the bladder completely, which may obscure any malignant lesions or cells within the pelvic region when the imaging is performed. By utilizing furosemide and hydration, the patient is able to expel more radioactive urine, and any that does remain within the bladder tends to become more diluted or less hot or less intense with radiation, and can help provide the reader with a less or unobstructed view of the pelvic structures. At this point, I'll hand things back over to Dr. Kim for a discussion of the assessment criteria available.
Thank you very much, Matt. So for the PSMA PET CT imaging, there are several response assessment that has been proposed recently from the publications, and we have one that I wanted to just point out in this presentation or the discussion is the PPP, or the PSMA PET progression criteria. And this is actually to assess the determine the progression versus a non-progression based upon a PSMA PET scans. So it has a same type of delineation as a PD and a non-PD, meant to be used for any local, regional, or systemic therapies. And the new lesion assessment is based upon the location of the new lesion plus size, and the intensity is incorporated in this case, which the bone scan has been had a bit of an issue with the non being able to quantify exactly how the pre-existing new lesions has been responding or progressing just with the bone scan. And the PPP criteria, they define progressive disease as the one of the following conditions or more. Would be a 2 or more new lesions that are PSMA positive, and that is a distant location lesions, or 1 new lesions that is also PSMA positive, and then also the other clinical data that is indicating the progression of the disease of the subject, or any size increase or the uptake increase that is more than 30%, as well as the clinical data suggesting that progression has been met for that particular subject. So any of the 3 criteria meets the PD, or not would be a non-PD per PPP criteria. There are also some limitations on these criteria, and that is being rather new. This criteria has not been completely validated yet, and also the 30% or more of that cutoff for the size increase or uptake increase that will lead to the PD has been rather arbitrarily chosen without any clear evidence yet. So there are a few things that needs to be validated for this criteria, as well as that what would be an appropriate cutoff to really guide the readers or the assessment person to follow. Also, there are another newer novel assessment criteria that has been suggested, which is called the RECIP 1.0. And also this is primarily using a PSMA as PET scan as the modality to assess for the prostate cancer patients. For this particular response assessment, they had retrospectively assessed the subjects or the patients who has been used the gallium or the fluoride PSMA agents in multiple different centers with the patient, particularly with the metastatic disease, with the lutetium PSMA therapy. And this was a retrospective, but they have found a correlation to the overall survival outcome, which the partial response or stable disease has been more superior outcome to the progressive disease has been found, with the statistically significant differences in between these response groups and progressing groups. And the PSMA assessment receipt 1.0 has suggested a delineation of their responses more than just simply a non-PD versus the PD. They do define complete response, partial response, and a stable disease as well. And their complete response is defined as absent or completely resolved any new lesions, or the lesions that has been found in the baseline has gone, and PSMA positive lesions are not found anymore. Partial response would be a more than 30% increase in a PSMA volume compared to the baseline, and then stable disease would be less than 30% decrease in PSMA volume, 30% or more decrease in PSMA volume with the new lesions, or less than 20% increase in a PSMA volume with or without the new lesions, and 20% or more increase in a PSMA volume without the new lesions. And lastly, the progressive disease would be a more than 20% increase in a PSMA volume with the new lesions. For the RECIP 1.0, they do also have a limitations has been found with these criteria, which also has not been validated response criteria for being very new assessment suggestions, and also needs to have any further prospectively planned validation will be required. Subject pool had no bone skin availability per the study design, and they are not able to compare a actual prognostic value against the PCWG3, which mainly uses bone scans as their radiographic outcomes. Also, the no correlation was found for the PFS, or the progression-free survival, due to the unavailability or inconsistent data for the clinical data for those subjects. And lastly, I will pass the presentation back to Catherine for what we do as a Merit very briefly.
Okay, thank you, Dr. Kim and Matthew, for the excellent overview of the PCWG3 reading criteria. And just to remind our attendees, you can always go to Merit's website to check out our webinars on other reading criteria. We've posted webinars on criteria such as RECIST 1.1 and RANO. And now we've reached the Q&A portion of the presentation. If you have any questions, please submit them now via the Q&A functionality. And while you are typing in your questions, I would like to take just a few minutes to introduce you to Merit. Okay. You may know Merit from our many years of managing clinical trials in ophthalmology. We have served biotech and pharmaceutical companies in their clinical endpoint analysis for over 10 years with a team of medical professionals and seasoned operational support staff. We offer support to our partners in a variety of therapeutic areas, including oncology and respiratory. Merit is more than just an imaging service provider. We are positioned to be an extension of your study team, and our approach is to really focus on 3 areas. Our software system, Excelsior, can handle all aspects of an imaging core lab in one system, from acquiring the images from a study site to performing an independent read and then transferring that data to a sponsor. Excelsior can manage and track images every step of the way. Merit also has a large network of over 100 radiologists and oncologists to help support studies in a variety of therapeutic areas. And finally, at Merit, we value a partner approach. We work really closely with our sponsors and our sites to build trust, partnership, and long-term relationships. Now, our proprietary software system, which is called Excelsior, delivers automation in a single system for all image and workflow management, resulting in clean, complete, and accurate data that will meet your clinical trial needs. Excelsior has been used in over 300 studies and is validated, and it's also an FDA 510(k) cleared medical device. Our unique role-based software allows all key stakeholders to work within one platform, regardless of their location. This is so exciting because all data is housed within one system. The images from the sites, the workflow tracking, the queries, the read assessment data, everything is in one system, and it avoids the need for multiple systems to have to be configured to talk to one another. So we will now open the discussion for any questions you might have. And I'm just going to check out our Q&A. Before we do that, I just wanted to point out on our slide, we have our LinkedIn information. So after this presentation, please feel free to look for us on LinkedIn or also on our website. Okay. And it looks like we have some questions. The first question, it is, we are currently using PCWG3 for some of our existing studies. What are the main differences and benefits of implementing the more updated PCWG3 response criteria? Dr. Kim, I think that sounds like a question for you.
Thank you very much for Catherine, and thank you for the question. So there aren't very much update from the PCWG2 to the 3. In fact, in terms of the radiographic reading assessment, there are new suggestions per RECIST 1.0 to the 1.1 from PCWG2 to 3, particularly for visceral metastasis. But other than that, the bone scan reading assessment, the 2+2 progression criteria has been maintained from the PCWG2 to the 3. So in terms of the imaging assessment, there isn't that much of assessment change other than following a new guidance from the 1.1, how the nodal lesions are now differently assessed for the short axis of measurements and stuff like that from the RECIST 1.1 to the 1.0.
Okay, great. Thank you. Okay, I have another question. I noticed that the 2 imaging modalities discussed were nuclear-based. Are there any other ways that research teams image prostate cancer?
Yeah, I'd be happy to field this one, Catherine. So historically, some of the traditional ways to image prostate cancer is you can utilize transrectal ultrasound, especially for biopsy purposes, prostate MRIs, especially the morphologic T2 weighted images are very helpful. PET CT and PET MRI are very helpful as well, especially as a lot more facilities start to have access to the PET MRI machines as well. And then within nuclear medicine as well, the bone scans are still very efficient and popular. Prostate scans are still out there and available, but many facilities are starting to shy away from utilizing that particular exam in favor of other more sensitive imaging modalities and exams, such as the PSMA PET CT exams that we discussed earlier today.
Okay, thank you, Matthew. That's great. Dr. Kim, anything to add to that question?
I think Matthew actually covered really well on all of the imaging modalities that could be used. Other than that, there are some bone scan analysis that could work slightly different, such as the bone scan index might be another thing, but that's still in the nuclear medicine imaging, but just additional assessment methodology or way to quantify the bone scans because of the PCWG3 only really assess the bone count or the lesion count as the main driving factor for the progressive disease. And then that there has been concerns raised that how pre-existing lesions that lights up in the bone scans only has a count as the only way to assess, but doesn't have any quantitative measurement methodology for nuclear medicine. So PSMA definitely adds a lot of values using possibly the uptake or the volume assessment, or also the bone scan index is something that could be added to assessing the bone lesions to the prostate cancer patients, which now with all these AI or better analysis tools that are more automated, seems like those are things that's being added into and being investigated, how the lesions can be better quantified to assess the patient's status.
Okay, that's a great thought. So it sounds like when someone is designing a study, they'll have to kind of take into account what is best for the patients in the study, what imaging is going to be best used for their benefit, but also too for the study design and what's going to work well for the PCWG3 criteria.
I totally agree. Yeah, thank
Okay,
you.
that's great.
Yep.
Okay, it looks like we have another. Oh, okay, this is a good question. And I don't know if this is specific to just PCWG3. Is all of this information usually captured in a study's protocol? So I can kind of take a stab at that one first. And I think that the answer I'm going to give is specific for this criteria and really any criteria. One thing that we know is any kind of imaging has to be written into a study's protocol. It will be part of the schedule of assessments. It's what the sites will need to be aware of so they can do the appropriate imaging. But from, Merit's point of view, we will really expand upon what is in the protocol. So what we'll do is we'll take PCWG3 or really any reading criteria that is referenced in a study's protocol, and we really expand upon that in the charter. So the charter is really our guiding document where we will not only outline all of our workflows and processes that we will follow when working with one of our sponsor partners. We'll really go into a lot more detail with the reading criteria, what exactly the readers will be capturing during their read. There might be some kind of slight modification to really any reading criteria that's published. We've had sponsors want to kind of change or tweak things a little bit just to suit their, the endpoints that they're looking at and really what the study's goals are. And so we would capture that in the charter. So really to answer the question, this information is captured in the study protocol, but usually it goes into a lot more detail in the charter and even in our imaging procedure manuals that we would share with the sites. So those would be probably the best places to record all of that very, very detailed reading criteria information. Okay. It looks like we've got one last question. And Dr. Kim, I think this one will be for you. What key elements are collected in a read ECRF during a PCWG3 read?
Yeah, thank you very much for the question. So as we discussed earlier, it is important that all the imaging bone scans are annotated with each lesion. So either like an X marks or the circular things so the radiologist can click through and record the lesion locations. And then each lesions will have a lesion ID associated with that annotations. Tumor state or the lesion state is recorded. And then also, as we discussed, the bone lesion count differences of the new emerging lesions at the baseline to the week 8. And then week 8 to any post week 8 needs to be recorded just to give that bone lesion indicator that can lead to a progression versus non-progression determinations. And then on the ECRF, of course, we will record any of the response outcomes like a non-PD, PD, and also any of the RECIST 1-1 outcomes for the other part of the scans like an MR and CT. And then, of course, the time point, imaging, procedure dates, and every other information that's associated with imaging should be also on some part of the ECRF so that the data capture is complete.
Okay, great. Thank you. And it looks like we have one last question, and then we will wrap things up to be respectful of everyone's time. Is Merit able to analyze images collectively for a given patient over time to get an overview of one's disease while participating in a trial? Okay. So I can provide a few thoughts on that, and then I'll turn that over to you, Dr. Kim. Yes, we do. In our reads, what we do, it's called a sequential locked time point presentation. So we will have a reader or 2 readers, whatever the paradigm is. They will assess a patient over time, and they will assess a patient time point by time point, really the same way a site would. So the reader will get the time points presented to them one by one in order. They're presented and they're locked. So this is very similar to what would happen at the site. So we're able to really see over time what the subject's disease is doing from time point to time point. Okay, Dr. Kim, I didn't know if you wanted to add anything to that.
I don't think so, Catherine. You covered primary functions of the Excelsior. We do have a diagram viewers presented to the reader with the configurable data capturing form for response criteria specific with any additional questions that or the data that would like to be captured. So those will be presented to the reader as their reading platform. Basically, Catherine mentioned, yeah, we do provide the lab time sequential presentation, oftentimes to reduce any biases on the reading processes. And by workflow, any of the images that doesn't match per protocol adjudication variables also can be presented to another reader to adjudicate on any time point that is necessary and get those data cleaned up for the sponsors to provide the study data. Yeah.
Okay, great, thank you. Well, we have reached the end of our Q&A session. We're at the end of our 45-minute time period. I really want to thank everyone for taking the time to join us today. We really do appreciate that. You can stay up to date on additional primary endpoint related content by following our company page on LinkedIn. Please stay tuned for more information regarding our upcoming webinars. You can always go back to our website and view our past webinars on demand as well. We want to thank everyone for being here, and I hope you have a great rest of your day. Thank you.
Thank you very much.
Thank you.